Hello everybody. Today we'll talk about the last segment of our acute kidney injury, that is the renal replacement therapy, which is very important because earlier all the modalities of renal replacement therapy were considered as a last resort or a final resort to manage a patient or bring out the patient from an acute kidney injury. But now in today's generation, it has become a standard form of modality to improve survival as well as life expectancy and to reduce the morbidity of a patient. So, let us first know what are the indications of RRT in an ICU setup. So, in an ICU setup, to initiate an renal replacement therapy, definitely there should be a life-threatening conditions like severe metabolic acidosis with a pH of less than 7.1. Then definitely hyperkalemia with ECG changes, and it is even refractory to your medical management like your potassium kexlitrazine, your glucose insulin boluses, as well as your saline nebulizations, your Lasix infusion. So, refractory to all the medical management, definitely hyperkalemia or a potassium levels more than 7 with ECG changes, definitely renal replacement therapy is the first mainstay of treatment. Pulmonary edema refractory to diuretic therapy and positive pressure ventilation. This might not be a clear-cut indication because pulmonary edema in nowadays is very well managed with help of positive pressure ventilation as well as diuretic therapy. But in very acute emergency situations wherein it is refractory to diuresis and patient is not able to tolerate the positive pressure ventilation, then definitely having some amount of ultrafiltration gives a lot of relief. Then uremic complications like encephalopathy, pericarditis, neuropathy, bleeding. Of course, dyselectrolytemias, especially dyselectrolytemias like hypernatremia, hyponatremia, hypomagnesemia, hypermagnesemia, all of which are refractory to your medical management. Then there can be some non-emergent conditions like solute control in cases of high urea levels like urea more than 200, or in patients with fluid overload where you are weaning a patient and you want to extubate the patient but you think like your fluid overload might cause some difficulty in weaning, or in drug overdosages like lithium, salicylate, barbiturates, ethylene glycol, methanol, or newer oral anticoagulants like dabigatran, where you want to reverse the effects of dabigatran and take a patient for an emergent surgery or to reduce the bleeding, or there is an intracranial hemorrhage and secondary to your NOACs and you want to reduce the bleeding or coagulation tendencies, definitely HD or your renal replacement therapy forms the mainstay of treatment. So, how do you choose a modality of renal replacement therapy? There are various modalities of renal replacement therapy available. So, how do you choose like which one to give? Definitely the choice depends on the hemodynamic stability of the patient. So, hemodynamic stability of the patient forms a very important thing. So, if the patient is hemodynamically unstable, then the modality is very much different. If the patient is hemodynamically stable, we can go for a much easier version of modality. Then your local expertise available, the age of the patient as well as vascular access, whichever you can give to the patient. So, what are the various modalities available in ICU wherein we can use our renal replacement therapies are definitely the most common one which all of us will be knowing, intermittent hemodialysis. Then there is CRRT, which is continuous renal replacement therapy, which is a little complex one but very useful. Then we have hybrid therapies, that is a bridging therapy between the intermittent hemodialysis and the CRRT, that is the sustained low efficiency dialysis or the SLED therapies. And we have a very cost effective and the cheap inexpensive method which does not require any complicated maneuvers, that is the peritoneal dialysis, which is using peritoneum as your natural semi-permeable membrane.